down in South Africa. And joining me today, obviously, is my good friend and co-host, Dr. Mark Bose, a phenomenal restorative dentist and a brilliant DSD master. And again, a friend and colleague and periodontist in waiting, Dr. Jonathan Dutoy, who most of you who know our research, we work very closely and do a lot of research together, who will be hosting today. So a big warm welcome to everybody from around the world. And I see there's quite a big group from everywhere. So welcome to everybody. It's really a pleasure and an honor to have you. Firstly, I know there's so many people around there's so many things on. So how does one actually keep up with it? We are going live. It will be available on our website. So if you do miss it, you want to share it with your friends, don't be shy. It will be available at a later stage as well. But for us to go ahead, what I want to do first, while we're starting, is I just want to share with you and say thank you to MegaGen for the sponsorship to make this happen. We can't do this without them to get the numbers and to get the everything online the way we do. So MegaGen, thank you very much, Sean, Matthews, especially Dr. Park, really appreciate it. And also just to mention about Dental XP, for those of you who don't know, I'm a very big lover of Dental XP. For those of you who don't know what Dental XP is, go to dentalxp.com, go and look online. It's probably the best online education facility that you can have for every single type of training that you want to do. So go and check online, go and look at it, and you won't be sorry. It's something that you can really look at. So what we're going to do now is we're going to carry on, and we're going to start with just a rehash. And before we start, I just want to ask everybody to go and like our Facebook page, go and like our Implant and Aesthetic Academy linked Instagram page, join us at our website. There's lots more video, there's lots more content there, and we're building it all the time. So come and join us, come and enjoy what we're doing. Just to rehash, give us a synopsis of what was happening last time. We had this patient who was referred by the orthodontist to us, who had ankylosed teeth. The teeth weren't moving. When we looked at the case and we took the orthodontics off, because obviously things were going nowhere, so we had to stop the orthodontics. The patients also had a massive infection on the upper right-hand central, which was one of the main complaints. And if you want to go back and you want to see what happened beforehand, please go online. The stuff is there. It's on Facebook, and it'll be on our website. You can go online and go and watch the previous portion, so you get an idea of where Mark and I really sat down and discussed this case in detail. So just to go back to what we were looking at, it was quite a difficult case because this is a very highly aesthetic and very challenging case, because the patient's request was, I want my smile back. And it was no small challenge for us because of the fact that we had so many pathological complications here. Apical infections, external and apical root resorptions. We had ankylosis. We had so many problems. We had gingival issues, incisal issues. You can see the apical resorption. I'm just going to go through this very, very quickly just to show you. In the 1-1 especially, our biggest problem here was that we had buccal and palatal destruction, which meant that the type of bone augmentation that we required in this area was a huge graft that was required, regardless of what type of technique that you chose, whether you chose a routine GBR technique using titanium mesh, using titanium for reinforced membrane, or utilizing just Curie techniques, which obviously would be the one that I would prefer. So it was a massive part of our decision-making and treatment planning here. The other tooth itself, which was the one that we really had a huge discussion, Mark and I, is do we save it, don't we? There's obviously massive ethical issues around the decision on this one. But in the end, we decided that because of the massive infection, because of the fact the root canal treatment was done so well, because of the fact that there was so much destruction of the inside portion, that if Mark had to now go and prepare the tooth for a crown, the long-term prognosis would have been poor. The one massive thing that really made a huge difference for us, and which really decided this technique of treatment rather than GBR. And the other technique was that the patient categorically said to us, I don't want surgery. I want to do the quickest, I want to do the easiest, I want to get into out of a denture and into a bridge as fast as possible. What can we do? We spoke about all the 6 different techniques that we had. So we really spent our time discussing all the options with him so the patient could be in with us on the treatment. Once he also saw the digital smile design that Mark did and he realized what the aesthetic final outcome would be, and go back and look at the previous talk that we had, he then, with us, we decided that the best option would be to rather do socket preservation in the central so that it minimized the amount of surgical treatment that we had, and we could then get to a provisional bridge fairly quickly so that we could then get him into something that's as physical and firm as possible. And so that was the treatment flow around that. Mark, is there anything you want to add to that?
Not really. I just think the only other thing we should probably mention is that the rest of his dentition was really entirely healthy. So, you know, it wasn't like we were looking at this as being part of a full mouth rehabilitation. It was that we were specifically having to focus in this specific area of the mouth. And that really we wanted, also from a restorative point of view, I wanted the best platform from a predictability, aesthetics, and long-term going forwards. And so that was for me the requirement, which happened to be as well for the patient.
Absolutely, absolutely. Okay, so if we take it from there, let's carry on and let's get into the treatment planning almost immediately, into the surgery almost immediately. So basically what we've done is we've got all our guides, we've got Marcus made us surgical guides, we've got surgical stents, we've got everything has been done. Now, I'd want to also just reiterate that this case was done in 2012 and 2013. So it's very much at the early phases. And when we start looking at socket shield, partial extraction therapy, root membrane type techniques, we have evolved those techniques quite dramatically over the years. So what you see today is not what you would actually see us doing now, and how we would do things would probably differ in certain ways that we would do things. So please be aware of that, and we're open to take questions. Also, what you'll see is, you'll see at the bottom, there will be links. There'll be a small little thing which says link, and where it says link, there will be Jonathan will be putting up a link to the publication, just so that you can also see where we're coming from a scientific point of view, that what we're doing is not just kind of our own technique and our own stuff, but it's really a whole lot of scientific work that's been put together over the years. Okay, so what we have here, and we've just brought out a new publication, which I'll give you the reference for it now. It hasn't come out yet, in the International Journal of Aesthetic Dentistry. That was supposed to be out in February, but obviously with COVID, it's now been delayed. But normally what we do is, when we start a case like this, the first thing that we're going to do is we're going to decoronate the crowns. And as you can see from here, the decoronation of the crowns is done to gum level. And this very much, even at that stage, it very much matches the step-by-step protocols that myself, Jonathan, Maurice, Professor Katlin Naj, we have just put out this new publication that dictates a new step-by-step protocol. I was on Omid Mohagadaz's hot seat the other day, and go and watch his YouTube video. We also have it on our line. You can go and watch it and see. It gives every step of the way. It takes that whole publication, and it takes the case and breaks it down step by step. And the reason we do that, and the reason why we have created that, is so that we can try and make this more predictable for you. Because this is not an easy technique. It is a difficult technique. It's challenging, but yet an interesting thing that somebody told me, that Basil Mizrahi, when I was having a chat with him on his forum, he said to me, one of the things why he liked socket shield, and it made so much sense to me, was that as a restorative dentist, he's very used to working with a turbine. He's very used to working with a drill. So he has very good feedback. And that then makes that technique a lot easier for him as a restorative dentist, he said, compared to surgeons. That was a prosthodontist point of view, not from a periodontist point of view. But anyway, So in essence, we're going to take you through this, and I'm going to show you, we're going to end up with the complications a little bit later. But let's go through the techniques. So the first thing we've done is cut it down to bone level. Normally what we would do is we'd now use Gates-Glidden burrs. In those days, we didn't use the Gates-Glidden burrs. We pretty much resected using fast handpiece resections. We used the Comet handpiece. Obviously, we've also come out now with a new MegaGen kit, which is a partial extraction therapy kit. They also have a root membrane kit, which is from the Greek group, from Miltus Mitzias. So that there are two different kits that they use that give you the options. So have a look at both of them. So what we've done in this case is we've now separated the palatal and the buccal portions. Now this is critical because what socket shield is the whole concept of socket shield by Marcus Hertzler is here to prevent the collapse of the buccal tissue. And we're going to see what happens in the socket shield areas compared to the socket preservation area, which most people at this day and age, most people would normally go for socket preservation extraction, socket preservation, or immediate implant with soft tissue grafts, or there are lots of different techniques that people go for. Some people just put the implant in and put like a highly sintered bone, which doesn't resorb quickly like a xenograft, and it doesn't work for me. I don't find that those techniques give me the predictability that I'm looking for in this type of case. So the whole concept of this is to keep that buccal portion of root. So as Chuck Schwimmer always says, out with the bad, leave the good. Okay, so we're leaving the good portion of the root, and the only reason that we're leaving that portion of the root is so that we're preventing that buccal plate. We're preventing the bundle bone from collapsing. So by allowing the bundle bone to be maintained and by stopping that collapse of the bundle bone, we are then going to allow and stabilize that tissue and not get any collapse of that tissue. So the question comes, what happens to that piece of root? It stays there for the rest of the patient's life. What happens to the palatal portion? We remove that palatal portion, and as you can see, we take out the palatal portion, okay? And there you can see the article that I was alluding to up there, which will be coming out soon in the International Journal of Aesthetic Dentistry. So we've removed the palatal portion, we've removed the root, we've spent a lot of time curetting out we've spent a lot of time curetting out the tooth in this area. We've spent a lot of time with debriding, cleaning, etc. So here you can see what's left of it. You can see the tooth with the apicectomy on the right-hand side. You can see, obviously, a round drill was used to do the apicectomy in this case, which is where some of the problem comes. We all know these days apicectomy should be done. You should cut the root off very flat, making sure that you've eliminated all the accessory canals. You can see from both of these areas, you can see where we've made sure that we've eliminated the apices, we've eliminated all the gutta perca, which is absolutely essential in socket shield cases. We then go and we then debride the socket. High suction, small suction, light and magnification are key to being able to get into the socket to make sure that you've eliminated all the oysters, all the infection, everything that's there. You can rinse out with chlorhexidine, you can rinse out with metronidazole, you can rinse out with tetracycline. There's a lot of different techniques. You can use photoablation using laser therapy. In cases like this, I often use my water layers to just decontaminate the socket even further, especially since it had so much infection in there. And we'll do that to all three of the sockets as we did in this case. The next thing that we're going to do, once we've now extracted, we're now going to prepare the apical portion of the socket, ensuring that the apex has been removed and all the gutta perca is removed. The next phase that we're going to do is we are going to then take away the coronal portion to bone level, and that's this portion over here. We're going to cut this all the way down to bone level, and once we've got that down to bone level, what we're then going to do is we're then going to create a chamfer. Now, this is from the old days when we used to do just a bevel, which was described by Marcus Hertzler and his team. And we have now changed this to a chamfer, and there's a link over there to the new technique, the prosthetic space required for a socket shield, which we published in the Journal of Prosthetic Dentistry. And Jonathan will put that link down for everybody so you can actually see that, go and read it and see what's important and where it's important to create and what shape it is to create the chamfer, how deep should the chamfer be, etc., and things like that. So we've now gone, we've decontaminated, we've removed everything. And now the problem is that we had, if you recall correctly, I'm going to quickly go back to this x-ray and show you how we had in this area, we had the apical infection in that area. And with the apical infection in that area, it was important now with that large apical hole that we had at the apex there, we need to now get access to that area because it was a fairly large hole. Now, if it's a fairly small hole, and if you're placing your implant very far palatal to the hole, you can just fill the inside with bone without raising a flap. But when your area is quite large and the apical dehiscence is quite, the apical fenestration is quite large, as you can see in this 3D rendering that we have, it's not something that you want to just fill with bone because the implant is going to be close to that area. You need to do some form of GBR. And if we have a look now, these are the two different techniques that we use. In the old days, we used to use the aesthetic buccal flap. And again, there'll be a link to that. That is a technique that Maria Steigmann put together. He put in 2007 in the International Journal of Peri and Restorative. And it's a very nice flap. It's an apicectomy flap. We use this for a lot of different techniques where we want to get access to the apex. And that really allows us to get inside and to see exactly what's going on, to get access to those apical areas. These days, however, this is the technique that I'm utilizing, and it's really you can see we basically just make a, sorry, we just want to just go back there. Let's just go back there. I just want to annotate this just in the drawing. So basically what we do is we make a single incision in that area. And that single incision now allows me just to work much more minimalistically. Obviously, now you need a microscope. You need very high magnification. I work with 6x magnification, so that's high enough. But working with a microscope as well, a surgical microscope, certainly makes a huge difference. And the nice thing about this is that it's very small and very atraumatic and much kinder to the patient. So this is the way we do things these days. If you do have multiple apices that you've got to treat, then obviously a bigger flap is a much better option. And you can see here how we are making sure that we've got a lot of space away from the gingival margin to make sure that we have no impact on the gingival margin. And this incision should be made in bone. Okay, it's very, very important that it's made in bone. You can make a rounded incision if you want to. I way prefer to do a incision that's kind of got that line. Okay, I'm going to take the red off there just to show a little bit better. But a lot of people kind of make that kind of line. I find when I've got square corners that I can always suture the corners together first, and I find I get a much neater suturing in the end. So that's just a personal preference, but whatever you prefer to choose, there's no right or wrong. It's just what you find works for you. So the next thing you'll see here from this case with that type of graft that we've done, you can see now where we've got all the apical area there. You can see where the oyster's sitting. You can see once we've cleaned out all the tissue, you can see the fairly large fenestration that we left with. And this is just too big a fenestration for us to leave because that is going to collapse. Following the placement of the implant, okay, so we've done our socket shield, we've got everything sorted. We've now placed our implant. We've got good primary stability using an implant which has got very good thread design, which is going to give us the apical stability. If I have a situation where I've got a large abscess at the base and I cannot get stability with my implant apically, then I would rather do a delayed approach, place bone, cover up the whole area, come back later, called a Glocker technique, which was a technique described by Marcus Glocker in about 2016, 2015. So there's a technique for that as well if you're not able to do that. Went through the standard sandwich technique. The sandwich technique is the classic Homley Wang style technique of placing autogenous bone first against the implant, and we got that from our drilling protocols and from scraping. We then placed a pericardium membrane. I personally, when I'm using membranes, I prefer to use the pericardium membrane because of the fact that it seems to be more stable than the standard collagen membranes, but really, you can use anything here. I certainly wouldn't go for a non-resorbable membrane because that means you might have to come back later and remove it, or if it gets exposed, there's complications. And I think a resorbable membrane, when you are working within the bony envelope, is more than adequate. And I think the ideal treatment for this type of situation. The PRF that we place over the top of this, please remember, at this point in time, there's no real data to show that PRF is going to help with my bone grafting at all. It depends on who you look at. If you look at Rick Miron's work, Rick Miron is quite clear about the fact that he's against. He doesn't see any viability in it. If you look at other guys, Nelson Pinto and Joseph Chukrun, they are more into the side where they show that bone augmentation works. I'm not a firm believer that it's going to do anything for my bone augmentation. And the reason it's on here is purely for soft tissue healing, because we do know, and there is very good evidence, that soft tissue healing is going to make a huge difference with PRF. So we line it with PRF membranes over the top and we suture closed. Here you can see the apical X-rays, that show us our guide pins. Very, very important to take X-rays as we're going along, as our new publication will show. Number one, am I missing the teeth next door? Number two, have I removed the apical infection? Number three, sorry, not the apical infection, but the apex of the root. Number three, have I removed all the gutta perca from that area? And we can actually now evaluate and see that we've got a cleaner area. The stuff that you see here, this stuff is all inside the soft tissue. So these little parts of amalgam are within the soft tissue and not within the bone, because we spent a lot of time when I saw that trying to remove all those parts to make sure that we've cleaned everything up. Once that is done, what we did here, and this is the interesting part, and this is where things get really interesting, is you can see here what we've done is we followed all the normal protocols. We've placed our implants as far palatal as normal, which is pretty much what everybody prescribes, Cavani, Evans, Dennis Tarnow, etc., etc. We've placed it palatal. We've placed it around 1.5 millimeters below the buccal portion of the root. So we've used the buccal gingiva as is well described in our publication. And what we've done as well is with the socket preservation, we've done the classic ice cream cone technique. Again, there'll be a link towards that for that technique, which was well described by Dennis Tarnow quite a few years ago, utilizing a piece of collagen membrane, resorbable membrane, put to the back, closed up. And the World Workshop actually says that this is the standard of care. This is what we need to do. We need to put bone. We need to preserve the ridge. It's going to give us a very good result. And certainly it's going to prevent some collapse. Will it form bone? I am very wary of that. I'm not a firm believer in socket preservation that's going to form bone. There are too many times that I've gone back into my own socket shields, socket preservations, where the bone that I formed, I had to scrape out and start again. And I think we see it so often when people show cases, they either show flapless work, or when they do open, they have to regraft. And I'm just not sure that that's just a little unfair to the patient. Are we really giving our patients the best treatment in that regard, rather than doing the grafting once off at the time? But this is a Pontic site, so we had to do something. We couldn't do a root submergence. We couldn't do a Pontic shield. There was nothing we could do here except socket preservation. So we went for the classic style socket preservation. Sockets using the ice cream tone technique, using the membrane, closing up. We de-epithelialized the outside. We didn't put a soft tissue graft over the outside, and that's something that my good colleague Snezana Pol for the what she calls the Ivan technique, and you can see Dental XP would have closed up. But the interesting thing is the World Workshop says it's not necessary. And the question comes is, was this a mistake? Because you're going to see the complication we had at a later stage. If we look on the right-hand side, you can see the suturing that we've done. And for anyone who wants to go and learn about suturing, Marcus Hertzler did a beautiful thing on suturing. And certainly I follow his protocols and techniques. But what I want to do now is I want to start the first poll. Okay, we're going to go to the next slide, and we're going to launch the first poll. And I want you all now to give me an idea about what you would do. And the more people that look at the poll, the more people that actually give us an idea of what you do, the better. How would you have handled the socket preservation case? What technique would you have used to close up the flap? How many of you would have used the socket seal technique by Kobe Lunsberg, that single piece of tissue, a nice tissue punch that's just sutured over the top? How many of you would have taken a free gingival graft and tucked it buccal and palatal? How many of you would have used PRF and a collagen sponge? How many would have done a rotated palatal flap, which is part of the Ivan technique that Snezana talks about? And how many of you think that we didn't need to do anything, which is pretty much what the World Workshop is telling us not to do? So at this point in time, we've got about 60 people out of 200 come. We've got about 200 people that are online, and the rest there. Let's choose something. You haven't got too long to sit on the fence. You've got to give us an answer as soon as you can, so we can get on with the whole thing. So we're not here the whole afternoon. But that's very interesting. Okay, so I'm just going to give it another few minutes. Let's get up to 100 people at least. So it gives us a good number of people to do it. After we've got 100, I'm going to end. 2 more to go. Your choice, your choice, your choice. If you do your poll now, you will also get this free thing. Okay, now you decide. Okay, great. Now there's a huge rush. Okay. All right, so I'm going to end now. Okay, so we're ending the poll. Sorry, you guys got to be a little bit quicker. So let's share the results with you. And it's pretty much, I think, as expected, because the funny thing is whenever you watch Facebook, you get an idea of what people would show. And I think 45% showed they would use collagen sponge PRF. So it's pretty much what I've done here, because I've used a collagen membrane to close up the shield. In those days, we weren't so big on PRF. I probably would have used PRF at the same time, I must be honest. The question comes is how effective is it? So 45% of the people said PRF or collagen sponge. The next one after that was rotated palatal flap, which was 25%. And then from there, 20% said that there's no need for closure. And 6% decided on a free gingival graft, and only 4% decided on the punch. That's interesting because we see a hell of a lot of patients who really just use the punch on Facebook. So it's an interesting result. And in this case, I did what the majority would have done, where I just used a collagen membrane, which is similar to a collagen sponge. And let's see what happens now with what we got. Let's look at the healing, and let's look and see what's going on. So here you can see we used 2 Megagen AnyRidge implants in this case. You can see we placed them quite deep. And I want you to see here, I think this side, if I look at the mesial side of the 1-2, I could have maybe left my shield a little bit higher. This is better on the right hand, on the 2-1. This is much better positioning of my shields. Remember that my buccal portion, it might seem deep here, but it's important to note that the buccal portion is related to where the buccal bone is, not the interproximal bone. So it looks much deeper than it really is. So 10 days of post-op now, what was happening in this time, we were really bringing our patients back a lot to follow up because this was very much the early days of Socket Shield. We weren't sure what was going on. There were no real protocols as to what was happening. So after 10 days, this is what the case looked like. We had excellent wound healing in the flap. You can see here, utilizing monofin 6-0 suture, which is pretty much what I use as a routine. Very little wicking, very good soft tissue healing. So the GBR area healed very well. Did the PRF help to some degree? Possibly. If we look at the occlusal surface, what do we see? And the crazy thing is that within 10 days, that collagen membrane that I put over the top is gone. It has been dissolved by hydrolysis, by the enzymes from inside the mouth. If we look at the case 1 week after that, okay, so it's now 17 days post-op, okay, or 20 days post-op. You can see how nicely the flap is healing. You can see the area around the implants are healing very nicely. We've maintained nice ridge width, but the area is exposed. Now, theoretically speaking, this is the norm, okay? What do we have here? How is that good enough? Is that going to granulate closed? 9 times out of 10 it does. It just granulates closed. But let's see what happens, because this comes down to now predictability, reproducibility. And I also want to say this is real world. How often have we seen over the last couple of weeks the most beautiful work that you can imagine? And you only see the beautiful work. You don't see the stuff that goes wrong. I want to make sure that you understand that a lot of the cases that we see are the one-offs. And the one-offs are not always, the exceptions are not always the rules. So we have to be careful when we look at our own techniques and stuff like that. And that's why I think it's so critical that Mark and I share this case with you. So you can see what we have here. You can see the open. Almost 2 weeks later, you can see what's happening with this case. So now I'm going to hand you over to Mark, and Mark is going to talk a little bit about provisionalization options.
Thanks, Howie. That's a great job that you've done so far, to be honest. I certainly couldn't have done it any better than you. Right. Again, you know, what we have to remind ourselves is that this was 7 years ago when we were talking about what were the options for provisionalization of the patient. And the possibilities really were, as you can see, a partial acrylic denture, a chrome cobalt denture, which I don't think is going to be that much difference to the surgical site to acrylic denture, certainly more costs. And then the provision of a lab fabricated acrylic or composite bridge. So again, this becomes really difficult if we're having to take it on and off, certainly, and if it's this span, I think that there's a possibility of complications with the bridge itself. And then a bonded bridge. So, you know, I think that when we treated this patient, we were really, the key thing was we were not sure about immediate load protocols for these sorts of cases. So we really went on a more conservative option, which was to provide the patient with something that didn't unnecessarily pose problems or complications with the treatment that we were in the process of doing. So I think at this point it would be interesting to see, using the poll, what would be the treatment of choice, because as I say, we've already kind of alluded to where we were going to go. So was there a poll there, Howie?
There's a poll. We're going to put up the poll right now, and we are going to stop sharing that poll, and we are going to go to the new poll now. Sorry, I've just gone out of there. Let's get the new poll on provisional 2. Launch poll. Let's go back to... Okay, we can just bring in, I've just gone out of the thing quickly. I see people are a lot quicker now on the uptake with the provisional. I'm going to go back to the presentation in a second. Okay, there we go. Mark, just an interesting thing, while the poll is going on, It's always
Yeah.
fascinating for me because patients obviously like non-removable provisionals. And I think that's
Yes.
always the
Yes.
choice from a patient point of view. Would you agree with that?
Definitely.
But the
Um,
problem, just to continue,
yeah.
then
No, no, Carol.
the problem from my side, from a surgical side, is that the provisional becomes absolutely a nightmare to manage food, checking to see that the surgical incisions have closed. I way prefer a partial acrylic denture as a provisional because it really allows cleanliness and things like that, access, easy access. What's your feeling?
Yeah, I also think that in a case like this, while we're waiting for healing to happen, it allows more flexibility with regards to deciding the key factors like the contours of the abutment areas and pontic areas. So it just allows a little bit more time before we jump in and start to reshape tissues. But again, if we're going to talk about abutments and healing abutments, and maybe this is a prudent time to just add a little bit about customized healing abutments, which would have been maybe a more ideal protocol in a case like this rather than a small healing abutment. But again, we have to remind ourselves that we're 7 years ago, and obviously this is something that we would definitely relook at in terms of managing that abutment issue. Is that good?
Yeah, 100%. I think the one thing that we forgot to put in here is we forgot to put in the immediate load bridge, which I think
Yes.
you'll explain why I'm gonna end the poll now, and let's just share the results. So Mark, if you want to talk us through that.
Yeah, I mean, obviously the immediate load bridge today would have been most likely the way to go, because we would have been able to start understanding about the tissue shaping right from the surgical phase and supporting all the tissue that was there already. But of course, 7 years ago, we weren't sure really. We were not pushing the boundaries, but we didn't understand actually the ability to utilize this tissue shaping process either through a customized healing abutment or even better, an immediate load protocol. So, again, it was being cautious, but managing the case in the most predictable way to get the best aesthetic outcome. So that's where things would have differed definitely from 7 years ago to today. And again, that goes on obviously your insertion talks that you can get. So we would be as a restorative guided by the surgeon at this stage. So although that might be our wish, it might still be that we need to go back to the partial denture. So that's a surgical decision as to whether we go immediate load.
Yeah, I think at this phase, I would totally agree with you. I think doing it today, there's not a doubt in my mind we would have gone for immediate load in this case. But obviously at that stage, as Dennis Tana always keeps telling us, one miracle at a time. But just to share the thing, interestingly, 43%, the highest amount partial acrylic denture. I'm glad to see I got it right twice. Okay, lucky. Okay, chrome cobalt, not many. I added this in because I don't know if Basil Mizrahi is here. Basil is a superb operator who did a case, and I did a case with him last night, and he mentioned that as an option. It's not something I normally would do because of the cost implications of it. But I would imagine that sometimes when one requires the strength, that a chrome cobalt is a possibility. A provisional lab fabricated acrylic or composite bridge. Obviously, if you've got prep teeth, Mark, then certainly that would be a great option. Yeah. But again, if we're prepping teeth next door, are we damaging them? And number two, if we have got prep teeth, does one more prep damage the tooth even further that it requires now an endo? So therefore, the bonded bridge obviously is an option, but then debonding becomes an issue. And that's why I think that the partial acrylic denture is such a nice option, because it gives us the broad variation. There's no doubt, though, that what it doesn't give us, okay, is it doesn't give us the stability of the tissue. And I think you alluded to that. Am I right?
Yes, I did. About either going for an immediate load shaping the tissue right from day one, or alternatively to a customized healing abutment. which has the benefit of the tissue control, but obviously not for a fixed prosthesis for the patient. So it's a kind of happy medium between either just a small round healing abutment or, the ideal.
Yeah. And I know also Rian Wolfart, who also works with us closely at the Academy, he also tends to put a cover screw on and actually then ovates into the sockets as well, using a denture as well, which is also another technique. And I think I've seen Henk Pretorius also do that one sort of an interesting way to actually develop the tissue in that way. So here you can see we did an ovate Pontic. We kept the tissue off the socket shields as much as we can. And you can see at 1 month follow-up, you can now start to see how we've maintained the integrity of the sockets in the socket shield. So the socket shields are doing their job. They are preventing collapse. Interestingly enough, if we look at the Pontic site, if we start now going to the Pontic site, we can start to see that even with the best socket preservation, okay, the best technique or what most people have chosen, we are still starting to get collapse of the tissue. In other words, it's not giving us the perfect result. And this is where I think partial extraction therapy comes into the fact that we want to try and maintain things. If I could root submerge this tooth a la Maurice Salama, if I could Pontic shield it a la Howard Gluckman, then I would definitely want to do that. But obviously in this case, we couldn't do it. And this is the result. So if we look at the base looks good. But when we look at the transition zone, and you, Mark, you'd agree the transition zone is key. And if we look at that transition zone, that is where our problem comes. So if we have a look at this, Mark, can you just take it away from here?
Yeah, so the important thing that I would say that when we're working in a case like this, most of the time it's a team that is involved. In other words, there might be a surgical and a restorative element to it. It's super important that we don't see these cases as being defined by surgery and Prostho, that we all manage the case together. So that often with the surgical case, I will only get involved maybe with the Prostho right at the end, whereas there could have been 1 or 2 small steps during the healing phase that would have had a big differential on the outcome. And so it's important that we see these cases as they heal. And so this was a prime example where we wanted to create pressure on the Pontic site to try and develop papillas and to try and develop the soft tissue. But what happened is that with the lack of tissue volume there, as it was collapsing, we ended up having to push, and the end result was a compromise now on the white aesthetics. In other words, the tooth was getting too long, and we still have to always keep referring back to what was the ideal design that we settled on in the smile design. And now we are moving away from that. So what I did on the right side, you can see I cut back the Pontic to go back to the correct tooth design and to the correct position of the intended soft tissue margin, not the healing soft tissue margin, and right. Keep working from that end result backwards. And so from here, we started to see the collapse, and we started the problem started to unfold.
And obviously, Mark, from what we said at the last time, where you spoke about digital smile design and the importance of digital smile design and how we are able to give the patient an idea of what we are actually going to do right from the beginning. This denture that you made was made based on the DSD. So the patient is already getting used to the idea of what he's going to look like. Am I right?
Exactly. And you can see in the Pontic site that because of the healing, we're having to push the length of the tooth and move away from the ideal situation. So that was something that then prompted us to maybe make a different decision in the treatment.
Okay. All right, so moving on now, if we have a look now at the CBCT at 6 months, we have a look and we see that we've got really fantastic bone growth. The hole that we had has been closed up with the GBR technique that we're doing it. And we kind of expect nothing less, because we're really doing a technique that's really nicely, it's well within the envelope, it's well within, it's a well-contained 4-wall defect. So graft stability, space maintenance, blood supply, everything's there for it to be able to get what it wants. If we look at the other side, at the 1-2 side, again, we've got good primary stability. We've got good anchorage. Everything's good. And again, I think without a doubt, Mark, we would have done an immediate provisional in this case.
Definitely.
Definitely. At the whole thing. So let's have a look at 4 months and see what 4 months actually shows us. And you can see at 4 months we've pretty much got everything kind of looking pretty good here. You can see in this area there's a little bit of bone that we just flick out. If you can see the collapse of the tissue here, just in the top, in the most important part. And other than that, we now need to start to develop the soft tissue around the implants. And I think, Mark, you would agree this is critical, and it's even more critical for socket shield, because what we need to do now is we need to develop that soft tissue, and that's why we went at 4 months. We didn't just go straight to the final, because this is such a high aesthetic value case. We had to go through a provisional, Mark.
Yeah, I mean, I think that for us, it's a standard protocol that we're not going to go ever from this sort of situation with a small healing abutment straight to the final ceramic restorations, either a single tooth or certainly in a more complicated case like this. And particularly because we could start to see that the problem area of the Pontic site was potentially going to be a problem. And so once we start having to move away from the ideal design, I think we have to have a second look at the area. But there's no question that we need to start to get, because there's also a loss of papilla in a way. The tissue has flattened, that we need to start to develop this. And there's no other way that I know than through temporary temporary bridge or temporary crown situations, implant crown situations.
Yeah.
And that we have the ability to change the shape to get the ideal situation as we're going through, because that initial bridge that we're going to fit might not be exactly the right shape to develop the tissue, but we have the ability to change the shape of the bridge in order to change the shape of the tissue, so that we maintain, or we can get exactly what it was we were setting out to in the first place.
Mark, there's one more thing that I think is absolutely critical from a surgical point of view, and from not going, and for anyone who's ever heard my lectures on treatment in the aesthetic zone, they know categorically that we do not ever place round abutments, and yet here we were. But again, this is many years back, and we learned from our mistakes. And one of the reasons why a provisional bridge, despite everything that Mark has spoken about, from a socket shield point of view, from a partial extraction therapy point of view, one of the key factors about having a provisional bridge is to allow us to shape, is to allow us to get the contours right. And Mark's going to show you the contours and describe the contours. But I want to know that when that provisional goes in and we take it out to do a final soft tissue assessment, that I have no internal exposure. Because the highest risk of internal exposure, the highest complication of socket shield is internal exposure, as we showed in our publication, myself, Maurice Salam, and Jonathan, and we'll have a link to that a little bit later. But to be able to put the provisional in, to be able to take the provisional out in a couple of months' time or a month's time, once the tissue has shaped, you'll be able to visualize any complications. And if there is a complication with the socket shield, you can cut the shield away, you can trim the profile, the subcritical contour of the bridge, etc., so that you can manage that complication before you go for final. So that's just the final word. The other thing that I want to show you is that as much as partial extraction therapy in multiple teeth gives you very, very good results from a buccopalatal collapse, we still tend to get some collapse of the papillae. And some people will tell you that you can get a perfect result every time. If I'm honest in my results, and I'll show you in this result itself, it doesn't happen all the time. Would it have been better if I had a provisional bridge there? There's a distinct possibility that it might have been. I think maybe the lack of support of that might have led to that. But I think the key factor is that don't expect it. And if you don't get it, don't beat yourself up that you've done something wrong, because I don't find it as predictable as other people are saying. Do I get better papillae than without socket shield and thing? There's not even a debate. Does a single socket shield, one tooth next to another, two implants next to each other that have been done at different dates, we can get almost perfect papilla all the time, okay? But it's just when we have multiple teeth or full arch cases that we tend not to. So the red area, you can see the critical area where we've still got this area. You can see how nice and healthy the tissue looks. And Mark, I think everything was going well up until this point. And
No.
Mark, I think you want to go through this?
Yeah, everything looked great, and we were ready to move on to the first, or the transitional prosthetic phase, where we're going to start shaping tissues. And we're fortunate that there'd been some nice work done by Shu and Lee in this paper 2010 about just describing exactly what were the demands of this transition phase from the implant head to what we saw above the pink. Okay, because this was a really important area that hadn't been written about a lot. We had had a lot of information about implant surfaces, about integration, and then about the white stuff, which was, ceramics, with shapes, all of that. But this was a critical phase, a part that really needed a lot of attention, certainly in a high aesthetic case like this. And so they broke it down into two distinct areas. One, the subcritical contour, or sometimes I even refer to that as the transitional zone. So in other words, the zone that we're getting towards the part of the abutment that's really going to make the difference about the shape of the tissue that we're going to see, the gingival margin, because that's really what we're interested in. And so the subcritical contour, really for us, the indication was to give as much space to the tissue as possible. So to create the most hollow but most stable from a prosthetic and a design point of view, so that the tissue could fill in. And then the critical contour was about 1 millimeter to 1.5 millimeters at the intended gingival margin. So that's important. So we were going to place this where we wanted the new gingival margin to be. And so this is an important thing that is not, it's something that's predetermined by the DSD and in the lab. And then we have the ability to change the critical contour, in other words, to adapt to the shape that we're looking for when it comes to the final prosthetics. So the important part for shaping tissue is really the critical contour. The subcritical contour really is a hollow area just to allow volume. But when it comes to changing gingival shapes and trying to create the correct gingival shape, the area that we really have to focus in on is the critical, which is that area around about 1 millimeter, 1.5 millimeters from the intended gingival. So it's the intended gingival margin. So, and by moving that, we have the ability to determine where the new gingival margin goes. So from that, we used the DSD, we used the original wax up to determine obviously where the incisal edges needed to go. That was really simple, the simple part. And then we had to, don't forget, go and create the new transitional zone or subcritical contour, hollow as possible, and place the critical contour in the ideal situation to give us the ideal gingival margins. And from the top picture on the left, what we can see is that we must remember here that we're going from a round healing abutment to an anatomical shape that's going to start shaping the tissue, and hence we're going to see a lot of blanching. And this is probably the only time in prosthodontics that we're happy to see this level of blanching. And what's important is that the blanching must disappear, and you'll see from the first picture to the second picture was 10 minutes. And then by the time the patient left the appointment, and I would never let a patient leave my office while they were still blanching. I think that's a critical bit of information to give. And so just by placing the subcritical contours in the right place already, when I look at the situation we have, and remember, this is just from 1 minute. We went from a fairly flat gingival contour to already having nice scallops and starting to get some sort of papilla. This is one appointment, but the importance is that we've placed the critical contours in the right place, which was determined by obviously the DSD. So I hope that makes sense.
Thanks, Mark. I think the key factor now, and if anyone hasn't noticed by now, is that there's something glaringly obviously happening in this time. So if we go back to what we had, to the healed sites that we had at 4 months, and this is now 2 months later when Mark is actually going to place this, you can see that something really unhappy is happening. So over the area where we had done the socket preservation, this is now 6 months later, we have developed a fistula in that area. And this is now, but this was our first complication that we had in this case, because now everything's looking great. We're looking to finish, and now it's like, whoa, we now have to now take a step back. I think the one lucky thing, Mark, you would agree, is that he's in a provisional now. So at least he's looking good. It's looking much better, although you haven't dealt with the lateral yet, so there's still discrepancy in the incisor lines. But at least from that point of view, we're in a much happier process. So now we can kind of slow the treatment down a little bit, luckily, because if they still have to go in a denture, then often you have a very unhappy patient. So we were lucky in that regard that we had the provisional, but now we have this complication. And it's not something I anticipated or I had discussed with the patient, because I've done so many socket preservations over the years, and it's not something that we often get. So the question comes down to, how did we manage the case straight away? The minute we saw this, what did we do? And the first thing that we did was we did local drainage. We got inside, we localized the area, we put a small curette through this little fistula, and we tried to take out as much as we could. Put in a laser, water laser, try to clean as much as we could. Sorry, I wasn't using water laser in those days. I was using a diode laser. We also inject local metronidazole. The concentration of the metronidazole is about 100 milligrams per 500 mils. It's the normal intravenous metronidazole that we use. And we inject around 2-3 millimeters, just some local stuff. It's purely anecdotal. It is something I do as a routine for a lot of my surgeries, just to try and make sure that I've killed any bug that's around there. And I also put the patient on a systemic antibiotic and try and keep them healthy and happy. So that's really the immediate treatment that we've got to do. And now we have to plan to actually get in and open up. So that was when Mark referred him back to me saying, hey, Howard, there's a problem. I'm like, hey, Mark, thanks very much. You know, that's the initial treatment we did on day one. Then we brought the patient back. So the question always comes to mind is why? What is the reason? Is there a problem with the patient's healing response? Did I not debride my socket properly? Was I not good enough at my socket debridement? And God knows, dentists, I think, are probably the hardest on themselves. Everything you've done is your own fault. If you're anything like me, I can't sleep for a week because I think that I've done everything wrong. Did I not do socket closure? Would socket closure have made a difference here? Would I have not got contamination, or did the bug come from deeper below? And was my handling of the bone initially poor? Did one of my staff sneeze on the bone? Or hopefully not, because we all wear masks and use all our thing. But was there an aberrant bug flying around the room that landed on the bone? What was my management? How did I, you know what I mean? There's so many possibilities, and we can't really look at. So the patient then came back, and now we're getting the patient back for the proper treatment. And interestingly enough, now you can see, after cleaning out a lot of the bone that's happened around there, you can see the area started to collapse even more. Okay, and if we now go cleaning even further, it's going to get even worse. But interestingly enough, if we have a look at the areas, if we have a look at the socket shields, okay, if we have a look at that area, and if you have a look at that area, you can see there's absolutely no collapse whatsoever. And this, again, reiterates for me what partial extraction therapy does for us. Just time and time and time again. And Mark, I'm sure you will agree. So
100%.
the fact of the matter is, the next thing that we did now is we now created a incision, a smile-shaped incision. And what I was able to do through that smile-shaped incision is create a pouch, clean out, rinse out, laser out, antibiotics, everything got thrown at this thing to try and clean out any sort of debris that was there. If the patient came back and I found that the draining sinus had healed, I probably would have done no more than a soft tissue graft. But because when the patient came back, although there was no major suppuration, there was still a fistula, things had not healed. I had not taken care of things. So what we did under those circumstances, I'm just going to take that annotation away. What happened is we did a tuberosity graft from the a soft connective tissue graft from the tuberosity, which we know is the most fibrous tissue. We know it has the best properties. We also know from a number of studies that it's actually expands. It's very collagenous. It's incredible stuff. And this is actually going to give us the most stable. If we can take a nice piece of tissue from the tuberosity, it's going to give us the most stable tissue that we could actually hope for. So that's what we put inside. And then what happened is that Mark went and we readjusted the contours. Mark?
Yeah, so basically we put back the temporary bridge and we marked exactly, and you'll see with if you look behind the black line, there's a pencil mark as to where we would like the gingival margin of the pontic to be. So that's a key thing. So we're determining where things need to go. We're not waiting for healing to happen. We're helping the healing happen around what we would like the outcome to be. And so we're going to predetermine the shape of both the abutments, the temporary abutments and teeth, as well as the pontic, and creating the critical contour, which is that shape that's going to control the healing of that marginal tissue. But also you can see that we added on the pontic side some volume in order to push the tissue laterally. So, you know, it's not just when we think about it's a three-dimensional process that we have to think about when we're developing pontics and developing the tissue around the implant sites. So, you know, we must stop thinking two-dimensional just from a frontal point of view and think about three-dimensional. But again, you know, this critical contour area is going to be the thing that determines the new gingival margin, both on the implant sites and on the pontic side.
Okay, so what we've done now is we've put the bridge back after it's been modified. And now we suture the graft in place. That's the most critical part, making sure that there's no mobility. And then we want to bring the soft tissue down a little bit. So what we've done is we've released the tissue all the way up into the vestibule, and we do the over the occlusion sutures, which is a technique that Otto Zur described in the International Journal of Peri and Restorative Dentistry, a brilliant technique by them, and Marcus Hertzler. And again, we'll put a link to that article. Jonathan will put a link to that article so you can see how to do it. It's a very technically challenging type of suture, but a very rewarding one, because especially when you have a bridge like this, it allows you to coronally reposition and hold the tissue in place very, very well without using a sling, which a sling suture tends to give you markings on the soft tissue, which I really don't enjoy. So this is a technique that I really enjoy using very, very nicely. Again, we'll post the link to that. So here you can see 2 months after that is healed, the soft tissue has stabilized. Everything's looking good. We're very, very happy. You can see where the tissue's in. We've got great bulk. We've got everything now that we're looking for. We've got a nice emergence profile. I think, Mark, if things had stayed like this, we would have been over the moon. And absolutely everything would have been fine. But obviously, maybe embrasure spaces, which you're going to take a look at in a second. And here you can see. Sorry, Mark, I stole your thunder. My apologies.
What I think we have to do is really utilize this healing period to the maximum. And so, what does that mean? It means the reason that we have these temporary prosthetic appliances, whether they're bridges or crowns, is that we have the ability to reshape them while things heal in order to get the best aesthetic outcome. And again, when I looked at the situation on the left-hand photograph, I could see that the tooth proportions were not exactly as we had attempted or we had designed in the smile design. And one of the reasons was, of course, you can see the lack of papilla. So in other words, we're getting a tooth that really is not the right shape. So what we're doing is we're removing the temporaries, and here you can see that we're creating space in the embrasure for the papilla to grow. And really also at this point, we were changing the critical contour ever so slightly to get a different tooth shape. So, this is a useful period for us. It's not just a matter of sitting back and waiting for things to happen. We need to be proactive sometimes in changing the shapes of the temporaries in order to create the shape that we're trying to reach at the end of the day. So it's an important process.
It's actually, I think it just shows how critical it is. And as I said, from Basil Mizrahi's thing where he does the step-by-step and the slow development of the case, this is exactly what the importance is that slow. And again, Miguel Stanley's whole concept of slow dentistry, slowly developing, slowly getting to where we want to go to try and create the right sort of embrasure.
And I think that often, it's things like that. It's attention to detail. It's the small details that take a case that's really good to exceptional. And it's if you're prepared to really look for the detail and spend that little bit of time to make the difference, I think that's a really big issue.
Absolutely. So here we can see now after the final soft tissue healing, you can see number one, there's no more fistula. You can see we've got beautiful contours. You can look at the proportion of the soft tissue. There's a little bit of a lip of tissue around the ovate pontic that Mark has created, which really gives us a beautiful emergence profile. So from this point of view, we're like, okay, we've managed the complication. We're on a roll. Now we're getting ready for the final hurdle, and all's good, and it's all wonderful. And we go into the final prosthetics. Mark, take us through it.
Yeah, I mean, obviously, I haven't got too many detailed slides on that process, but what's super important is that if I've spent, or both of us have spent, and the patient has spent 3 or 4 months developing the soft tissue, we then go from that point and don't give all of this information, not some of it, all of this information to the laboratory, it's time that's just been wasted. So in these days, these things have changed. It's important to utilize custom impression copings, but not only impression copings, custom pontic design, so that the laboratory can copy exactly all of the things we've done in this 3, 4, 5, 6 month period, in whatever that time that it took to go from a round healing abutment to the point where we're ready to take impressions. So it's absolutely vital. It's not a nice step to have, that we have to really use all this information and give it to the laboratory in order that they don't change anything that we provided for that healing process. So it's just a standard protocol, I think, that you have to use if you're going to the trouble of using a temporary situation.
Mark, what instructions do you give to your technician to make sure that they follow that? Because often you find that the technicians just use a soft line, which means that they can put pressure on that, and then it becomes non-passive. What instructions do you give for that?
Yeah. I mean, obviously that they need to use a hard model to make sure that things fit back into that, and here they're going to wax it into this, so that, obviously it's no point in giving them a guide. In other words, to guide them, they have to work exactly to the shape that we've spent so many months trying to determine, because small differences on the not so much the subcritical contour, but small differences on the critical contour will have a profound effect on the visual outcome of the case, the gingival margin. So it's super important that they have the ability to copy this exactly.
So essentially, when you're putting the final bridge in, there should be no pressure?
No pressure.
Nothing. I think that's a key factor, because I think, it's such a common question that people ask, how long must the pressure be there for? And the answer is, when you're putting your final bridge in, your pressure should be there for 0. It should never be there, because if your pressure is there, then the tissue is going to move.
Yeah, I mean, you should be able to take the temporary out and put the final bridge in with 0 anesthesia, because there's no manipulation of tissue. Once you start to push tissue, it hurts the patient. So that's a good test.
Mark, another question. Has your technique changed since going digital, using digital impressions for this specific technique? How would you manage it?
Yeah, I think that what we're trying to do now is there's many different options, so that if we can also scan the soft tissue space that we have, scan the abutment as well as a scan abutment. So scan the shape of the temporary abutment or this transition phase. Then you can merge all of this information. And I think that's really a lot more accurate. Three files, exactly.
Sending 3 STL files, yeah.
Yes, yes.
I think that's pretty much, I mean, from a point of view of exactness, I mean, to cut and paste is the best option compared to allowing, hoping that your technician can actually work with a stone model and a non-stone model. Do you think?
Yeah, sure. So I often in a case like this will make 2 indexes so that I can actually take the bridge back and see that it fits into the silicon, and see how passive it fits into the silicon. So this also gives me a really good idea of whether the lab, so I don't make one like this, I make one for myself to check when it, I mean, obviously this was when we were working analog. So that gave me the ability to check, because I agree when you get the models back with the pink soft, that stuff it doesn't fit and it doesn't tell you anything. But if you have something to fit it yourself back to, you can then start to see whether they absolutely applied the shaping that we've been spending all this time trying to determine. So, yeah.
Cool. So you can see here, this is now at the restorative phase, and Mark, to take us through this.
Yeah, I'm not going to spend too much time. And this was obviously in the days pre-angled abutment correction possibilities. So this is why we went cement retained. Of course, we prefer screw retained wherever possible. I think the key element here is that the transition area that you can't see is exactly the same shape as the temporary. We've discussed that. But now the cementation line is going to be very close to the soft tissue margins so that we control the removal of cement. That's a key thing, so that you have to communicate with your lab exactly where you intend the margin of the abutment in the ceramic to be that interface. And then really, I think the other important thing that we utilize is that we pack cord around this just below that margin so that the cement can't go beyond that. And then I think the other key element is not to overfill the bridge with cement so that there's excess everywhere. I think when you're dealing with teeth, it's okay to fill the whole bridge or crown with cement, but it's really it's better not to have a huge amount of excess. So I think those are the really key factors for me here. We used obviously a zirconia abutment, as you can see from that. I think that was a standard approach.
I think you would agree. I think we all agree, and I think with Dennis Tarnow, Thomas Linkevicius was also talking about screw retained versus cement retained, and how screw retained is without a doubt the best option, and certainly something that we attempt to do. And I don't know who placed these implants, but they should have been placed better so you could do screw it.
Yeah, the only other thing I would say is that it's all very well to use angle correction abutments, but they also create an excess of space sometimes in an area that puts pressure in the wrong places. So that you have to be a little bit careful for, so that if your lab goes to angle corrected abutments like dynamic, or there's a bunch of them, that area from the implant to in the subcritical zone is sometimes over contoured because of the space they need for engineering. So that's something just to watch out for.
Cool. So we see the beautiful result that we've got in the Pontic zone now with the connective tissue graft, and we see a really nice soft tissue. But I don't know how many of you took a closer look and started to look at the apical area of where we did the connective tissue graft now, because now we're heading into complication number 2. And this was something that we did not expect at all. And this is, we wrote a paper on this for a couple of cases. In fact, we had 3 cases almost in a week of the same sort of thing. And it's not something that there's too much information about tuberosity grafting, because everybody punts the positives of tuberosity grafting. I want to show you one of the negatives tuberosity grafting that happens. And here, Mark, you can see the final result. You just want to talk through what you've done on the lateral and the materials.
Yeah, so the bridge was an Emax layered bridge. You know, and what you see is that, what you can't see, which is great, because the first attempt at the composite on the lateral, which is the 2-2, we used a universal type composite, and we ended up with too much translucency. So about the bottom of about 2-3 millimeters of that lateral is in fact composite. So it was important to get the transition of the composite in the tooth, so we lost the margin. And yeah, I think that what we were trying to do with the final prosthetics was copy exactly the design that we had created right in day one of the treatment planning process of the DSD. So we chose layered, obviously, because we wanted a high aesthetic result, and I think that's the only way versus monolithic. So yeah, bear in mind that we worked on 4 teeth here.
Who was the ceramist who worked on this, Mark?
That was Shane from DiCeram. Yeah, I've worked for a long time with him, and yeah, I think the key is that, you know, you and your lab need to communicate in terms of what you're trying to achieve. I think that one of the problems in dentistry is just lack of communication. So, you know, I'm a big advocate of communicating.
That your technician understands exactly what you need without you telling them.
Yes, exactly.
Okay, so if you have a look there at the before and after, where we started and where we came from, certainly a happy patient, huge improvement of where we came from. I think most would agree. Is it a perfect result? Without a doubt, it is not a perfect result. Would I prefer to have better papillae here? We definitely prefer to have perfect papillae here. If we have a look intraorally, now we start to look at the beginning, and this is the complication 2 that we were talking about, and this is the issue that became a problem for us and is still a problem to this day, and it's something that we weren't able to eliminate. So we managed to get beautiful contours on these, around the teeth, around the top, everywhere, but we had these 2 little nodules that were growing, these 2 little keloid hyperplastic areas that were growing, and we decided that we needed to remove this hyperplastic response. Even though from a lip line point of view, the patient couldn't see it, he could see it when he lifted his lip, and it's what we said in the first thing, a low lip line doesn't give you a get out of jail free card. And when we had a look at it, it really wasn't so bad, and unfortunately, in retrospect, I actually wish we hadn't touched it. Because unfortunately, the minute we touched this is the minute it actually got worse. And going through here, we had now multiple treatment options. We had electrosurge, erbium YAG, diode laser, I suppose carbon dioxide laser as well, scalpel, diamond burr, different types of gingivectomy burrs. There's all sorts of different options that we could have used here. And I'm very interested to start the poll and to see what the options are that we would have had for this one. So what would your treatment option be for this kind of problem? How would you manage this case? What would be your first thing? Obviously, if you haven't got an erbium YAG, you're not going to use one. But what do you think the most obvious, and how would you manage it? And I suppose the one thing I didn't put in there, which I should have, would have been don't touch the lesion, which I think if I look back in retrospect, I probably would have been my treatment of choice. So let's just see what we get now. Okay, we'll get to about 100, which is more than half. I suppose it's difficult to determine what you would use, because it really comes down to what you have in your office. You know, if you've got everything in your office, then you have a choice. If you don't have everything in your office, then certainly your choice of technique would be different. So I'm going to end the poll there, and I'm going to share the results then. Interestingly, diode laser is the one that we wanted the most. The next one after diode laser is diamond burr, which is the easiest one. why I'm not a big fan of diode, and there's no right or wrong here. I have to be honest. You have to understand there is no right or wrong, because ultimately it's whatever you are comfortable with. The one thing that I find with a diamond burr is that the amount of bleeding is so hectic with these cases that it often takes 20 to 30 minutes just to try and get the patient to stop bleeding. Electrosurge, I think electrosurge is pretty much not something that we use too often, and most people have moved over to lasers. Erbium YAG, the next one, the Erbium YAGs, the water laser, and obviously the ND YAG is another one. Two different types of lasers, each with different lasing mediums, different wavelengths, etc. And then the one least used was a scalpel. So fascinating what we've got here. I'm going to stop that sharing now, and we can share results, and we can just close that off. So let's have a look. Let's have a look now. What we did now. The first thing that I did in this case, I have a water laser, and I used it was probably at about 3 watts on the gingivectomy setting, the standard gingivectomy setting with water and air, pretty much the standard setting for gingivectomy. And I went over, I like my water laser because of the fact it doesn't burn the tissue as much, as there's much less lateral heat, and it's I find it more controlled than the diode, which I have both. So I have both options. So we went along and we lased away the tissue using the water lasers, and hoping that would be the end of it, and we wouldn't have too much of a problem. And the patient came back 2 months later, and lo and behold, things got worse. And now we had an option. Okay, well, there's no point in doing the same thing and expecting a different result, because that's just stupid. So we decided, okay, well, let's see if a change of wavelength, going to a diode laser, let's see if a diode laser would work. And we changed over to a diode laser, and we did just using the diode laser. And you can see the difference in how the tissue is charred, the charring of the tissue, because you don't have the cooling and the air from the diode. So we cut that down as much as we could. And as they say, a little birdie was walking down the road, a guy was walking down the road feeling all down and sad, and the little birdie said to him, cheer up, things could get worse. So he cheered up, and sure enough, things got worse. And here you can see pretty much how we ended up. It just grew and grew. So the more we actually started to try and mess with it, the worse it's got. And part of our water laser group and the laser group, I'm very interested to have a chat with them at a later stage, or for them to suggest even whether different energy settings could make a difference, if there's something that we could try different in this case. What we are doing at the moment is we are giving the patient, or we were giving the patient up until COVID-19 locked us down, we were giving the patient intralesional cortisone injections, because that's the only thing that really works for keloid. And unfortunately, it's not really working that well at this point in time. Mark?
Yeah, so I think that what's really important is if we do cases like this, not to assess them on the day we fit the final prosthesis, but really to evaluate them, over a long period of time, or the longest period of time thereafter. In other words, to kind of audit ourselves about the success of treatments, and be critical to ourselves about things that really we didn't do perfectly, or that we could have done better. And so, when we look at the original design, for sure, what I see is that we were missing the papilla between the centrals, and between the central and the lateral on the right side. And you've already mentioned that, that this is one of the things, even with socket shield, is not going to be predictable every time, and so, I think that we have to look at it and understand where we've compromised from the original design, which was the ideal treatment. And if we look at the gingival margins and the incisal edges, we've done really well. We manage these things really well, but there are small elements that are missing, and we have to accept that. As you've already said, don't beat ourselves up. But it's important just to really evaluate cases and see if there was maybe something that the next time we can do better. Because I think, too often, we don't really look at these things critically. We just move on to the next case. So, that's always something that I find really useful. but not to beat myself up.
Absolutely. So here you can see, this is now the 5-year result of this patient. You can see the CBCTs. We can see the 2-1 where we've still got the buccal bone still nicely intact in that area. So everything's still looking very, very good. Carrying on to finish off, you can see he doesn't have a very high lip line. So that's lucky that it hides the area, but it still bothers him. You know what I mean? Despite that fact, it still bothers him. But the good thing is that if we look at where we've maintained the gingival margins, the gingival levels, as much as I would love to have got more papilla, as I said, maybe I could have prepared the interproximal portion of the papilla of the socket shield better on the distal side, but it might also have been bone destruction from the infection that we had there. So we keep forgetting that we had a monstrous infection that went from buccal to palatal in central. So I think from that point of view, definitely not a bad result. Looking left and right, I'm sure most would agree. From an extremely difficult case that we took with and that we started with. So with that, I'd like to say a huge thank you, Mark, firstly to you, buddy. It's always a pleasure working with you, and it's always a pleasure planning and going through these cases, because there's so much debate, and I think it's the nicest thing about working in a team.
Yeah, can I just say one other thing, and you did mention it, and so often, you know, when we see cases, that we need to give obviously a shout out to our technicians who help us achieve these things. So it's super important. So just one more shout out to thank you to Shane at Diceram for you know, providing us with the kind of quality of ceramic work and detail that the lab always needs. Because if you don't have the lab helping us, all our work is really, you know, goes by the way. So yeah, that's the only thing I'd like to say.
So just a last thought to say, join us on our social media. A big thank you again to MegaGen. A big shout out to my dear friends, the Salamas, Team Atlanta, David Garber, Eddie Salama at Dental XP. Go and join them. Best group in town, best conferences, and without a doubt, some of the best courses. And I want you to say thank you. Join us on Thursday. Mark will be back with Jean van Leerop. They'll be dealing with a nice case. There'll be a new blurb coming out, a little video of me sitting behind my computer here, because we've got so much time on our hands. It's like Groundhog Day, having a marvelous time. Jonathan, are there any questions that we could go to at this point in time?
Right, Howard, we have a lot more questions this time than we did compared to part 1 last week. So I don't know, I'm gonna have to be a little bit selective with the questions, but let's see how far we go. The first question, from Facebook, if I read it verbatim, I have some questions. Do you have any tips to make sure the apex is completely gone with the socket shield? I've tried to brush from coronal towards the apex, but I felt it was difficult to see if I'd completely remove the apex. So that's likely for you, Howard, if you can just give some tips.
Yeah, there's only one way that you can do that really, and that's to continually take an X-ray. It's the same way as you'd be doing an endo. So what I do is it's impossible to see down the socket. So the only way that one can actually do it is to paint. If you feel that you've got everything, take an X-ray. The X-ray will tell you if the GP is gone. The X-ray will tell you if the apex is gone. It's clear as day. So it's the easiest, the simplest way. Take numerous X-rays until you can see that the entire apex has been removed. But if you are doing the painting from apically down, you're spot on, you're doing the right technique. Make sure that you're using a slow handpiece. Don't use a fast handpiece, because a fast handpiece can very quickly damage the buccal bone. So you're looking, the best thing is to use a blue ring, either a contra-angle blue ring. I use a straight handpiece with a 2 millimeter or 3 millimeter diamond to do that, and then you have much more haptic feedback, much more sensory feel to do that. So the answer is X-rays. Take as many X-rays as you can.
All right, second question, if you want to comment on placement depth, I'll read it to you. MegaGen implants procedure is to place the implant 1 millimeter subcrestal. Does that matter when you place a MegaGen implant with a socket shield compared to other implant brands?
I think it doesn't make a difference whether you're using Megagen or any other implant brand. I think all of them. I mean, okay, let's just get this straight. When you're using an external hex and you're not going to platform switch, then you need to place it at bone level. But most implants these days are platform switched. Most implants these days have some if they have internal external hexes, you can platform switch them, and if you can, then they're going to be placed exactly the same level as the Megagen. Obviously, from the Megagen point of view, you've got both platform switching and Morse taper connection, which is, in my opinion, and it's just my opinion, the best type of connection, and certainly for single teeth. So from that point of view, no micro motion, and you can place it. So most of them are platform switched. Most of them either conical or Morse taper, and therefore you can place them 1.5 millimeters below the buccal plate.
Right. Discussing the Pontic site, right, between the two implants, there was a question for the Pontic site, would you consider the socket chamber technique by Paul Weigel? Howard?
Yeah, I suppose anything's possible. I mean, there's lots of possibilities. I mean, Paul shows very nice results with his with the technique. I have no experience with it, so I can't say that I can. The tooth that we had, if you saw what the tooth looked like, it's very black. It was very poorly developed. Would I trim out that tooth and try and use that going forward? I don't think so. If I had a cleaner tooth with less infection, maybe. But I think that's a question you'd have to ask Paul. I have no experience, so I can't really give a comment on that.
I think, it's if you understand the biology of why you get remodeling of the socket following tooth extraction, I'd always wanted to ask him, how they would justify the fact that you could hold the blood clot in the socket by an ovate Pontic, there's the socket chamber technique, and offset the resorption of the bundle bone. I just don't see it happening. So that's what that's about. Okay, let's see if we can pose some more questions, and I think the bulk of them are restorative orientated. So Mark, let's pose some of these at you. How do you customize your impression copings, and how would you record the soft tissue developments at the Pontic area as well? That whole area, the 3 sites. How do you transfer that information after you've developed the soft tissue to the lab, Mark?
Yeah, so basically the customized impression coping is developed by taking an impression of the temporary bridge with implant fixtures, and then screwing an impression coping on, and then filling up that space. If we looked at that slide, filling up that space with either flowable composite or Duralay, and you would fill it up to the exact gingival margin. Okay, so the best way to show them then the Pontic site is, obviously I've shown them the shape of the Pontic, but they need to know exactly where to put the intended margin, and the easiest way is they're going to work off the next door central. So they're going to level them so that the margins are exactly the same. But a custom healing abutment a custom healing impression coping is the important thing, is that you need, as I say, to take an impression of the temporary bridge, and then copy that, and then utilize that as the impression. I mean, I think, so you literally going to take and make an index of the temporary bridge and utilize that. I mean, if we could go back to the slide, that was the easiest way to show it. But I don't know if that was a good explanation.
Okay, let's switch. Howard, retrospectively, would you have considered a roll flap from the palate to seal the socket graft site? Is Howard still with us, or?
I am. I think my camera's just gone a little bit. I think I'm going to be back with you in a second.
No problem.
Just
Okay.
carry on the
I'm
question.
going to ask Mark another question in the meantime.
Okay.
Do you add to the temps in the surgery, or do you get the technician to do it in the lab? And what materials are you using for your temps, your provisionals?
Okay, so the provisional is made out of acrylic, and all the changes unless obviously maybe there's something completely wrong with the length of the tooth, the incisal edge, then it's going to be remade. But all the gingival changes, so the critical contour changes, are going to be made chairside, because I want to evaluate those changes immediately. I put it back in the mouth, and if it's not the right change on the soft tissue, then I'm going to take it out, either remove or add, depending on where I want the tissue to go. So it has to be done chairside in terms of the pink changes. But in terms of white changes, so if, for instance, if the teeth were all too short, then clearly that has to go back to the lab. So in other words, if the incisal edges were wrong, then that's going to be most likely done in a lab-based change. But all soft tissue needs to be done chairside, because otherwise you can't evaluate the small changes that you're making in the flow of this temporary phase. So it's super important that. So as you put it back, you can see the tissue move in the direction that you intended to.
Mark, another question to add to that. Do you do a master verification jig after your master impression to ensure you've got a passive fit?
Yeah, so that's a good question. Obviously, there's less pressure when you're doing a cement retained restoration, because you're building that slight inaccuracy into the cement, if that makes sense, to the answer to that. But certainly, if we're doing screw retained, it becomes super important that you have some verification that you have accuracy. So yeah,
all right.
I think that's the only benefit of cement retained.
Okay, Howard, let's give you one or two last questions, and this again relates to the Pontic site that was grafted. Do you think a xenograft would have been a better choice of material for socket preservation because of its slow resorption?
It was xenograft that I used, and it's something that I've used almost exclusively for years and years. And it's something that I've now stopped using, and I've moved over almost entirely to allograft now, allograft and more synthetics like calcium phosphosilicates and lithium tricalcium phosphates. So no, could it have been that? Possibly. I do find that the more highly sintered material tend to become more quickly infected. What was crazy about this case is that everything was fine for 4 months. It only started at 6 months. So I just don't understand where it came from, how it got in there. Was it hiding inside there? The case makes no sense to me. Would the change in graft have made a difference? I don't think so. Your question beforehand to do some kind of soft tissue closure, would I have done that? I think I actually would. Going back now, I would definitely, following Snezana Pohl's Ivan technique, I would modify Ivan technique. I would definitely have gone for a rotated palatal flap, or what the Americans would know, a VIP CT, to close up that area and possibly have bulked out that tissue all at once, and maybe even improved on the papilla situation distally. So that's probably what I would have changed at that stage.
Maybe a last question, because it's quite similar to what you just answered. Someone asked now, would you have considered using a beta tricalcium phosphate, the ethos material, for socket preservation as a viable alternative?
Well, I think one of the problems with using highly resorbable materials, it all depends on a number of factors. In other words, if I put that in there, what am I looking to achieve? Am I looking to put bone in? So that I can put an implant in at a later stage? Or am I looking to put bone in that's going to maintain ridge stability? And I think if I was going to do a ridge preservation where I'm going to do an implant later, A, and B, if my ridge was fairly wide, that the tissue was well contained, then I think ethos is the perfect material. But in a case like this where I want no collapse, because remember that ethos material tends to resorb, one has to overbuild with tricalcium phosphates. I know Peter Fairbairn will probably disagree with me, but one has to overbuild with tricalcium phosphates because it collapses quickly and resorbs quickly. It's what's nice about the material is that's replaced by bone. But the problem is if I'd done that in this case, the chances and risks of the ridge collapsing further because of the fact that I didn't have a less resorbable material there, I believe would have been high. I don't know of any research, or if you do, Jonathan, where they've measured any tricalcium phosphates, ethos, or anything else, and looked at volumetric change in a socket preservation. So I don't think there's any data to show that. But my experience would say no.
Right. Look, we could answer a few more questions, but I think it's an hour, 40 minutes. I don't know if you agree,
Yeah.
Howard, Mark, if you'd like to wrap it up, and we could always answer some more questions on the shared video on Facebook, on the different groups.
Absolutely. Again, I just want to say thank you, Jonathan, Mark, Laura, sitting in the background there that no one can see. Thank you guys so much for everything. Thanks to everybody who joined us. It's a pleasure and an honor. And there's so much. You spoiled for choice with the best people in the world, giving webinars, giving talks, and you spent your time with us. So it's humbling and it's great. I hope we share real world cases. I hope we share honestly. And I hope we share cases and stuff that you can kind of go home and think and say, hey, I have the same kind of stuff. It's not just perfection. And from that, I say goodbye. Mark, from your side?
No, thanks, Harry. It's been a great experience going through this case. And, you know, that the nice thing is that it's actually quite a few years ago. We're not also showing stuff that we did yesterday. So you know, it's super important to show something that holds up over a period of time. And that we can be critical over a period of time. But again, it's about teamwork, you know, that in dentistry on our own, I think we can achieve so little, but together we can achieve so much. So, you know, it's paying attention to detail as well. So thanks a lot also to Jonathan and Lara. So it's been, yeah, my pleasure.
All right.
Thank you.
Right. Cheers, everyone.
Thanks, everyone.
Thanks, cheers.